from you because you're making it difficult for the big pharma to make money. So that's why they.
Yeah, I don't think so. There's 50 of us, and I don't think the 50 of us matter one going to matter one hill of beans to big.
Yeah, I agree with you.
So,
well, it's great, and it's also good to know that you're a Fafrum, Fa, Ma, and Adabma.
yeah. So that's A4M, a couple of A4Ms, and a couple of medical acupuncture degrees there. I'm not sure. I don't remember which ones are which. I think the last two are acupuncture, and this one is A4M. So,
yep. Well, we know you're very well qualified to speak to us. I'm really glad that you picked this topic because it's nice to hear somebody else kind of present a point of view on it. And,
So the whole point was that Dr. Halassa, you've been singing the praises of Methylene Blue ever since the second I met you, and I just had to put it in my own words and sort of in my own head and so I can figure out what it was what I could use it for, what was practical, what was in the literature, and I just tried to make a little bit of more sense out of it. So hopefully this is sort of like a Cliff Notes version. My latest projects are I'm writing I'm writing lectures and papers on summaries of 40 years as an anti-aging physician, A to Z, and so that's what I've been doing. So the Methylene Blue here, what we'll have is the last few slides I'll have are sort of a summary, and that's kind of what I'm doing for everything. So there's a lot of acupuncture in there, and there's a lot simple things that we can do, and so in the A's I had autism, adrenal fatigue, and endocrinology of anxiety, but again, just the highlights, that kind of thing. And the battlefield acupuncture. I don't know if any of you guys know what that is. The ear acupuncture for acute, pretty much any kind of acute problem. So anyway, tonight's topic is going to be Methylene Blue, and this is my take on it. I'm sure Dr. Halassa will have lots of comments, and but what I did was I went and went through the literature. I tried to make sense of it, and to sort of categorize things so that we had like a list of this is what it's used for, and here's the proof for it. I always write this only because I never know when these are going to turn into CME lectures. And so they always make you write this, no relevant financial relationships with ineligible companies. And I'm getting a little bit better at the cartoons and whatnot here. And again, an objective. So what is it? How does it work? What are the effects, clinical uses, and side effects and contraindications? So what is it? It's a stain. It's actually, it was made as a wool stain. It was developed in Germany in 1876. And it was a blue dye, and those places weren't very clean at that time. I don't know how clean they are now, but it was noticed that around using this dye to dye things blue, a lot of bacteria cells. It was a lot cleaner around the methylene blue stained areas than other areas. And it was then used to stain and visualize cells and microbes, and it could actually distinguish between live and dead living organisms. This was the age of the microscope was just starting to be used. It highlighted anatomical structures. It stained tuberculosis or TB bacteria. It stained malarial parasites, and it actually killed them. So this was, one of those sort of discoveries that was like a whoopsie kind of thing. It was a lot of things that were not expected. Sort of like Viagra, I guess. Some of these weight loss drugs, that we're using, the diabetes drugs for weight loss. So methylene blue inhibits guanylate cyclase. It prevents smooth muscle relaxation. It treats cyanide poisoning, and it actually lowers the levels of methemoglobin, and it's FDA approved for methemoglobinemia. It is a nitric oxide synthase inhibitor. It lowers nitric oxide. And that actually becomes important at higher doses. It inhibits the conversion of L-arginine to L-citrulline. So it will actually lower growth hormone also. So I've sort of categorized it here. And so on the left, the metabolic functions of methylene blue. And on the right here is the reference for it. So it increases oxygen consumption by up to 37 to 70%. It increases ATP production. It increases glucose utilization. It increases the NAD/NADH ratio and AMPK ratios also. It decreases lactic acid production. So it increases energy. Yeah, here. Okay. Acts as an antioxidant. It prevents intraperitoneal post-op adhesions. So they can use it as a as a sort of as a wash post-operatively. It acts as an alternative electron donor in the mitochondrial electron transport chain. It completely inhibits monoamine oxidase A, so it's an antidepressant, and it partially inhibits monoamine oxidase B. It increases cerebral blood flow. So just from this, this list of 10 metabolic functions, you can extrapolate the what it's used for. Being the hormone guy, I looked at what its effect on hormones and the effects of methylene blue on hormones. I have a list of increases and decreases at the end. What I have here for you are doses and uses of all the hormones, and this is what on the right hand side what methylene blue does to hormones. So it increases testosterone, sperm count, and motility. We can use it as one of the entities that we can use to increase testosterone without using testosterone. It decreases estrogen and acts as an aromatase inhibitor. It increases the uptake and increases ATP levels of progesterone. It upregulates IGF-1. It increases free T3 and decreases TSH. Remember, TSH and free T3 are inversely related. It decreases cortisol levels. It decreases DHEA. There was no literature I could find on pregnenolone, although pregnenolone increases prolactin and methylene blue decreases prolactin. So there's an inference there. And it decreases cyclic AMP activity of oxytocin. So this is just a little summary. Methylene blue will increase testosterone, progesterone, IGF-1, free T3, and DHEA. It will decrease estradiol, cortisol, pregnenolone, prolactin, and oxytocin. There's the references for all of those. Its effect on pro-inflammatory cytokines. It is useful in septic shock patients. 1 milligram per kilogram IV will increase vascular resistance, which will increase mean arterial pressure. So it's used for septic shock without a decrease in cardiac output. It will decrease the cytokines interleukins 1, 2, 6, 8, 12, and TNF alpha. Nitric oxide increases in septic shock, resulting in arterial vasodilatation. And so methylene blue will block this nitric oxide effect. Now, normally you want nitrous oxide because you want to increase vascular perfusion. But in this case, in septic shock, you want to do the opposite. Methylene blue ameliorates cisplatin-induced neurotoxicity by enhancing antioxidative capacity, energy metabolizes, and suppresses inflammatory parameters and oxidative stress. So methylene blue is useful for cisplatin-induced neurotoxicity and anything that's similar to it. These are the clinical uses of methylene blue. Methemoglobinemia, it's FDA approved. Vasoplegic syndrome, which is what we just described, septic shock syndrome. Pain reduction prior to anesthesia. Malaria. It prevents ifosfamide-induced encephalopathy. That's something I don't deal with very at all. It identifies parathyroid gland in surgical situations as a stain. It's an antiviral, antibacterial, and antifungal agent. We'll talk a little bit about parasites also. It's an antidepressant. It's useful in autism. It's an anti-neoplastic. It is useful for traumatic brain injury recovery, and there's a few miscellaneous indications also. So you can see it has quite a widespread, and we've been learning about this over the past 2.5, 3 years. All of these sort of the joys of methylene. Hopefully, we have it sort of in a succinct form here. Somebody's clinking glasses there. So hepatobiliary syndrome, a microbiology identification. It identifies intestinal lumen lesions. It's an antidote for heparin toxicity. It can help relieve high flow priapism, Alzheimer's disease. It can lessen the symptoms, and it can relieve the resistant plaque of psoriasis. So methemoglobinemia is oxidized hemoglobin loses its ability to carry oxygen. Ferrous 2 converts to ferrous 3. You get increased nitric oxide, cortisol, and pro-inflammatory cytokines. Symptoms are cyanosis, dyspnea on exertion, confusion, seizures, brain fog, coma, metabolic acidosis, headaches, inappropriate giddiness. You get a chocolate brown looking urine. The etiologies, there's a congenital type, and this is usually sort of a cosmetic type issue. The patients have a lot of cyanosis. There's also a cytochrome B5 reductase deficiency, and then there's a hemoglobin M glutamate replacing valine deficiency, and that's the one you'll see in the surgical issues. The etiologies of methemoglobinemia are all of these here. The cane anesthetics can do that, so you get this with anesthesia. Also, under 2 years of age, some of these oral agents can actually create a situation of methemoglobinemia, Oragel and Anbesol, to use that for teething. Cyanide and carbon monoxide poisoning, sodium nitrate, amyl nitrate poisoning, heavy metal toxicity, fluoride, formaldehyde, fluorine dioxide-based cleaning products, COVID-19, dapsone, and anti-malarial drugs can all cause methemoglobinemia. Just a couple of notes. The cane anesthetics, methylene blue quickens post-anesthetic awakening by up to anywhere from 15 to 40 minutes. Cyanide poisoning, methylene blue accepts electrons and acts as a redox agent, increases ATP, increases NAD-NADH ratio, maintains blood pressure, left ventricular contractility, body temperature. It decreases the oxygen deficit and decreases serum lactate levels. In COVID-19, it improves oxygenation and respiratory rate. So, Dr. Halassa was on this early. Usually it's a 1 milligram per kilogram as an IV. You can get up to 4 milligrams per kilogram. Anything higher than that, you're gonna run into some toxicity. You can start at 0.1 to 0.2 milliliters per kilogram over 30 minutes. You don't do it as an IV as a push or an IM or a bolus. You have to do it as a slow IV, especially for methemoglobinemia. Orally, you can begin 5 milligrams twice a day and increase it to 20 milligrams twice a day as tolerated. It's contraindicated with G6PD deficiency, and you need to monitor the liver and renal function. You need to reduce the dose by about 40% if they have some liver or renal impairment. You need to be careful with SSRIs, SNRIs, and MAO inhibitors. You can get a serotonin syndrome. Vasoplegic syndrome is pretty much what we discussed just a minute ago. It's hypotension despite normal or increased cardiac output. It's associated with a high mortality, especially after cardiopulmonary bypass. Methylene blue, it has a positive nitric oxide regulatory mechanism. It will decrease nitric oxide and increase systemic vascular resistance. So what you get an outpouring of vascular dilatation. Itself, Methylene Blue is not a vasoconstrictor. It blocks the cyclic GMP pathway, releasing cyclic AMP, and facilitates vasoconstriction. The dose here is 2 milligrams per kilogram IV, followed by a continuous infusion. Early intervention in the OR results in less mortality and morbidity versus late use, 0% in the OR versus 21%. So I'm not sure how many anesthesiologists we have here, but those are the FDA approved indications. For pain relief, it's an anti-inflammatory. It reduces sodium, potassium exchange in cells, and it will help with denervation tissue. Also, it decreases again nitric oxide signaling, cytokine activity, and it decreases inflammasome formation, decreases swelling, edema, and tissue destruction, and is effective for low back pain and for pruritus ani. It decreases nitric oxide signaling. It blocks GTP conversion to cyclic GMP. It results in the inhibition of smooth muscle relaxation. It decreases toll-like receptor 4, which activates NF-kappa beta, interleukins 1b6, TNF alpha. It decreases the binding of NF-kappa beta and P53, which affords pain relief. It upregulates TGF-beta receptors. It is synergistic with morphine and CCK, the neurohormone that decreases inflammatory mediators, and it downregulates the P2XR receptor, the main pain transmission pathway located in the dorsal root ganglia and central terminal of the primary efferent pathways. That's a long way of saying it dampens inflammation, and it is a fairly potent pain reliever. It decreases inflammasome expression. These are intracellular multi-protein complexes that process cytokine precursors into mature forms. It induces programmed inflammatory cell death. It inhibits inflammasome formation by decreasing cytokines and reactive oxidative stress, and it reduces inflammatory cytokines, interleukins 1b6 and TNF alpha. The end result is decreased tissue degradation and swelling. Sodium reduction. Methylene Blue inhibits sodium entrance through injured cell membranes. It acts as a gate immobilizing open pore blocker rather than as an inactivator of sodium movement, and it decreases neural firings in the microglia in the brain. The end result here is blockade of pain transmission. Methylene Blue, administered in cutaneous tissue, results in death of nerve endings. It blocks nerve conduction while destroying nerve endings around painful lumbar discs. Patient satisfaction with injectable Methylene Blue was at 91% versus 0.7% in the placebo group. As an anti-malarial agent, it was first reported versus Plasmodium in 1891. It's used in combination with artemisinin, which is wormwood, to reduce malaria gametocytes. And just as a personal note, my daughter had been in Africa for 4 years, and she ended up with a pretty severe case of malaria, pneumonia, and she had the liver damage also. And whatever they were doing, they weren't working, not working. And we used some wormwood, and I did have some Methylene Blue. This was in 2000. This was in 2010. So I did have a little experience with it way back then. I got it at a Western mall there that was in Nairobi. Methylene Blue has potent inhibitor effects on otherwise drug-resistant Plasmodium species, and it remains effective and rarely turns resistant. And this is just a personal opinion. I think it was abandoned for over almost 100 years, and so bugs like to live, and they get used to whatever it is we're trying to treat them with, and so we trot out this Methylene Blue after 100 years, and all of a sudden, they're susceptible to it. Ifostamide-induced encephalopathy. It's an alkylating agent that treats pediatric sarcomas. A major side effect is hemorrhagic cystitis and neurotoxicity. Symptoms are somnolence, neurologic deterioration, and coma. Methylene Blue 100% eliminated the chemo-induced encephalopathy. Dose was 50 milligrams IV Q4 hours. Typically need 4 doses. Resolution time was 72 hours. So again, this isn't anything that I deal with, but if you deal with pediatric cancers, keep this in mind. IV Methylene Blue for the parathyroid glands will stain them, and you'll be able to identify them. Sensitivity rate is 78.6%, similar to ultrasound or radionuclide imaging. 6% adverse reaction rate. 95% of the patients with reactions were in SSRIs, so those two don't mix. Methylene Blue is useful as an adjunct to standard pre-op imaging by facilitating a more rapid identification of abnormal parathyroids. As an antiviral, it's a preventative or therapeutic against the influenza virus H1N1 and the SARS-CoV-2, 2 to 3 milligrams per kilogram per day in divided doses for 7 to 10 days. We'll have the source for you there. Protocol included using N-acetylcysteine 1,500 milligrams plus vitamin C. It's active against flaviviruses, sort of the African dengue viruses, Zika viruses, West Nile, yellow fever, Japanese encephalitis, and tick-borne encephalitis. It inhibits hepatitis C when used with photodynamic therapy. Herpes simplex 1 is inactivated by low-dose methylene blue and photodynamic therapy, and it inactivates HIV-1 parvovirus, HCV, again with photodynamic therapy. As an antibacterial, it has potent antibacterial activity against Staph aureus, MRSA, Staph epidermidis, and Klebsiella pneumonia. You mix it with silver nanoparticles, and it's effective against gram-negative bacteria, E. coli, gram-positive bacteria, Staph aureus. Methylene blue and silver are more effective in a combination. They exhibit high photostability and oxygen singlet yield. Methylene blue and photodynamic therapy evidently killed selective drug-resistant Acinetobacter, Pseudomonas, and multi-drug-resistant Klebsiella. A dose of 50 milligrams per liter and red light of 80 joules per centimeter. It's effective against MRSA when used with a red light. When used with the helium laser at 632.8 nanometers and at 665 and 830 nanometers, it has a high bacterial effect on periodontal pathogens. I think, Mike, you have some sort of a contraption that can do that. Methylene blue may be used prophylactically against colonization of beta-lactam bacteria without promoting resistance. It's an antifungal. It's mediated through the mitochondrial dysfunction and disruption of the redox and membrane homeostasis. It's active against Candida, albicans, tropicalis, and cruzi. It disrupts the mitochondria and the redox status of fungal infections. It disrupts fungal membrane integrity and inhibits the yeast to hyphal transition that is essential for survival for the fungal virulence in the host body. So it's useful against yeast also. Here are all the references for that. This 153 was the reference for HIV and SARS. As a diagnostic and for parasites, methylene blue provides contrast between parasitic structures as compared to saline or an iodine mount. As a therapeutic agent, it may be administered alone or with red light or in combination with other anti-parasitic agents. And it's susceptible to all of these parasites are susceptible to all of to methylene blue. Trypsonia, Leishmania, Toxoplasma, Neospora, you can read them here. The microsporidial malaria, the visceral leishmaniasis, African sleeping sickness, toxoplasmosis, giardia, Chagas disease, Cryptosporum, Toxoplasma gondii, Encephalosium species, and Nosium species. Dose here would be 60 to 130 milligrams twice a day orally. They can be used sequentially or simultaneously with light therapy or other anti-parasitic agents. As an antidepressant, it has antidepressant, anxiolytic, and neuroprotective properties. Short and long-term remedies for bipolar depression without mania episodes, useful for depression and comorbidities in Alzheimer's and Parkinson's disease. It inhibits monoamine oxidase A completely, and it partially inhibits monoamine oxidase B. It's a non-selective inhibitor of nitric oxide synthase and guanylate cyclase. It inhibits nitrous oxide and cyclic AMP, which results in an antidepressant effect. High doses of nitric oxide are critical regulator of neuroinflammation, and it has a contrasting effect in the central nervous system. Low concentrations of nitric oxide are neuroprotective and mediate physiological signaling. High concentrations are neurotoxic. Increasing concentrations of nitric oxide enhance the production of relative nitrogen species, and reactive oxidative species, which are associated with an increase in pro-inflammatory cytokines. Methylene blue tempers mitochondrial dysfunction and redox imbalance, and dysfunction is linked to mood, anxiety, depression, and psychosis. Dose here would be 15 to 100 milligrams a day. Start at the low dose and take it up slowly. Here are the references for that. In autism, the SHANK3 mutation is frequently associated with the autistic spectrum. SHANK3 mutation leads to an increase of calcium ions. Calcium ion influx activates nitric oxide nitric oxide species, and it activates leading to a dramatic nitric oxide formation. Elevated nitric oxide leads to aberrant signaling pathways targeting intracellular proteins, resulting in synaptic, neuronal, and behavioral deficits. Mitochondrial metabolic dysfunction results with elevated oxidative stress. Methylene blue leads to a reduction of the electron transport complex genes, and it results in significantly lowered pyruvate dehydrogenase, 35%. Pyruvate dehydrogenase converts the pyruvate to acetyl-CoA. It results in an abnormal pyruvate lactate level. You can actually measure that. It affects up to 80% of the ASD patients. Symptoms include fatigue, gastrointestinal disorders, unusual types of neurodevelopmental regression, seizures, epilepsy, and motor delay. So that's a mitochondrial dysfunction. So biomarkers for mitochondrial dysfunction, direct ones here are lactate, pyruvate, and a lactate to pyruvate ratio, ubiquinone, alanine to lysine ratio, and acetylcarnine. Indirectly, you can get a CK level, carnitine level, AST, ALT, and ammonia level. And here's the labs to order for that. You can use those as biomarkers. Mitochondrial dysfunction is prevalent in autistic spectrum at about 5% versus a general population of 0.01%. ASD signs and symptoms with elevated mitochondrial dysfunction have elevated lactate levels in 78% of patients and pyruvate levels in 45% of the patients. This results in developmental regression, seizures, motor delay, GI abnormalities, and it's somewhat higher in the female gender than the autism spectrum itself. Autism spectrum is usually about 5 to 7 males to 1 female. So it's a little bit higher with the mitochondrial dysfunction here. Almost 80% of the cases are not associated with genetic abnormalities. You can use for these markers blood, urine, saliva, or central CSF fluid. Dry biomarkers, your history, and these are functional MRIs, ultrasounds is a way to diagnose. Remedies for the mitochondrial dysfunction. This is kind of a hot topic at the moment, and this is not just for autism. The ketogenic diet, coenzyme QA with PQQ, 100 milligrams with 20 of PQQ increase the coenzyme QA by 100 milligrams for every risk factor, depending on what you're dealing with. So things like diabetes, high cholesterol, family history, increase it up to 600 milligrams, 100 milligrams for each risk factor. Vitamin B2, 50 to 400 milligrams. Creatine, 5 grams per day. L-arginine, you can use if patients had a stroke, 500 milligrams per kilogram per day for up to 3 days, and 100 milligrams to 300 milligrams orally after that. L-carnitine, 100 to 1,000 milligrams IV or orally. Methylated B complex, mixed tocopherols, vitamin E, vitamin C, 5 milligrams per kilogram per day. Alpha lipoic acid, 50 to 200 milligrams per day. Leucorvan, I don't really recommend that one. And methylene blue, start at 5 to 10 milligrams per day, and you want to use 0.5 to 4 milligrams per kilogram per day. That's sort of your end dose there. This is just kind of a schematic of the same thing. These are your tools to manage mitochondrial dysfunction. Anti-neoplastic properties, methylene blue plus photodynamic therapy induces massive cell death of tumor cells. Normal cells are resistant to the methylene blue photodynamic therapy. So it will kill the cancer cells and leave the good cells alone. It increases oxygenation to the abnormal cells and increases ATP. It exhibits catalytic power on cells possessing aerobic oncolysis. Cancer cells switch from glucose oxygenation to glucose fermentation. This was known as the Warburg effect. Increased rate of glucose uptake and preferential production of lactate. Glucose stores get depleted. Fatty acids and proteins are then consumed. You get abnormal glucose metabolism plus mitochondrial dysfunction, and that brings out your cancer. Methylene blue selectively seeks out cancer cells and alters their metabolism. Methylene blue plus photodynamic therapy dissociates nitric oxide from the cytochrome C enzymes and restores cancer cells to normal. Prostate cancer, methylene blue plus photodynamic therapy reduces the viability of androgen-dependent and androgen-independent prostate cancer cells. It suppresses prostate cancer tumors by inhibiting colony formation. It disrupts prostate cancer cell migration. In pancreatic cancer, it decreases the growth and viability of pancreatic tumor cells in a dose and time-dependent manner compared to placebo. Melanomas, methylene blue plus photodynamic therapy promotes a decrease of 99% decrease in tumor volume and 75% in tumor weight. Methylene blue plus photodynamic therapy downregulates proliferating cell nuclear antigens. Bladder cancer, methylene blue has multimedia reactions throughout the intracellular proteins, RNA, DNA, with a decrease with loss of cytoplasmic granularity. Methylene blue cytotoxic effects is initiated in the cellular membranes and intracellular mitochondria. In the endometrial cancer, methylene blue in cervical injection ensures a mapping of the pelvic and infrapara-aortic structures with good global detection rate. In thyroid cancer, it also is useful for tumor localization. Lymphomas, it inhibits E2. E2 is a loop helix transcription factor. It's essential for B lymphocyte proliferation. E2A mutations are associated with beta cell leukemias and lymphomas. It preserves kidney function with cisplatin therapy. We mentioned that earlier. Cisplatin is an anti-neoplastic agent, 70 to 90% effective for head, neck, and gonad and ovaries and breast cancers. A third of cisplatin patients experience nephrotoxicity due to reabsorption of the cisplatin by the proximal tubules. Cell death in the proximal tubules is due to reactive oxidative stress. Cytokines involved are TNF-alpha, TGF-beta, and interleukin-6. Methylene blue at 4 milligrams per kilogram IV reverses the cisplatin-induced reactive oxidative stress. annual P blue. There are the references for that. Traumatic brain injury, methylene blue treatment significantly reduces neuronal mitochondrial dysfunction and increases ATP production caused by oxygen glucose deprivation. Methylene blue reduces neuronal apoptosis and increases blood-brain barrier integrity. It improves cognition and motor function caused by traumatic brain injury. It significantly improves neurological function. It inhibits microglial activation, decreases brain edema, increases autophagy. Methylene blue treatment minimizes traumatic brain injury lesion size, behavioral deficits, neuronal degeneration. Dose 1 hour after traumatic brain injury of 1 milligram per kilogram, 6 hours, 0.5 milligram per kilogram, and then a dose of 1 milligram per kilogram daily for 3 days. That's for an acute treatment. There are the references for that. Hepatobiliary syndrome, pulmonary vasodilatation due to increased cyclic GMP. Methylene blue increases your oxygenation, decreases alveolar arterial difference for partial pressure of oxygenation, and decreases that guanide cyclase. For microbiology identification, methylene blue easily identifies H. pylori. It identifies intestinal luminal lesions. It acts as an antidote for heparin toxicity if the patient is protamine sensitive. It relieves high flow priapism, and it functions as an alternative electron carrier, enhances brain metabolism, attenuates the formation of amyloid plaques and neurofibrillatory tangles. It partially repairs mitochondrial function. It increases cellular oxygenation and glucose uptake and ATP production. It's neuroprotective by improving astrocyte cellular respiration, and it relieves resistant plaque and psoriasis. There are the references for that. So side effects are the ones you see here: abdominal pain, chest pain, vertigo, headache, sweating, confusion, high blood pressure, shortness of breath, rapid heart rate, tremor. The skin and urine can turn blue or bluish green, red blood cell reduction, and jaundice in infants. And I've heard some instance in the oral form of some numbness or decreased sensitivity in the tongue. Contraindications are hypersensitivity to methylene blue, renal insufficiency, relatively contraindicated with G6PD deficiency and Heinz body anemia. It interacts with SSRIs. This is where we usually see any type of side effects. And MAO inhibitors can cause that serotonin syndrome. And it does interact with dapsone. We mentioned it for use for TB. And an oxidized hemoglobin causes hemolysis. Key takeaways: methylene blue is mediated through mitochondrial dysfunction and disruption of redox and membrane homeostasis. It inhibits nitric oxide signaling. It decreases cytokine activity. It reduces inflammasomes. The methylene blue inhibits guanylate cyclase, which is used for treatment in it prevents smooth muscle, which prevents smooth muscle relaxation. It's used for cyanide poisoning and methemoglobinemia. It is a nitric oxide synthase inhibitor. It inhibits L-arginine to L-citrulline. Here are this is just a recap of the metabolic effects: increases oxygenation, ATP, glucose utilization, NAD to NADH ratio. It decreases lactic acid production. It acts as an antioxidant. It prevents intraperitoneal post-op adhesions. It acts as an alternative electron donor. It inhibits monoamine oxidase A and partially monoamine oxidase B. It increases cerebral blood flow. Its effect on hormones: it increases testosterone, progesterone, IGF-1, free T3, and DHEA. It decreases estrogen, cortisol, pregnenolone, prolactin, and oxytocin. It's useful for clinical uses are in these syndromes, which we just discussed, and a couple of pearls here: hepatobiliary syndrome. It's useful for microbiology identification, intestinal lumen lesions, an antidote for heparin, high flow priapism, Alzheimer's disease symptoms, and plaque psoriasis. I just mentioned the side effects. So the last few slides are a summary that you can sort of copy and you keep by your desk side. hypersensitivity, severe renal insufficiency. It interacts with SSRIs and MAO inhibitors and interacts with Dapsone. And here are the references. And so quite a bit of information. Remember, we're on Tuesdays every Tuesday night. In fact, tomorrow night we have Ken Crowley on for us, 5 p.m. Anybody wants to get on and doesn't have our link, you can get me at either here or Dr. Halassa, and put my cell phone on, or my email address, doctrbil9@gmail.com. You can put it in the link there. And any questions? Go through the chat.
Yeah, we got some in the chat here, Bill. Let me see if I can go through this with you here real quick. One of the things somebody asked is, what dose will inhibit nitric oxide, and should we use nitric oxide supplement when when we're using
Well,
methylene?
if you're wanting to use methylene blue, that they sort of kind of counteract each other. So there, there's a specific reason to be using methylene blue. So the nitric oxide would probably, sort of not be indicated with it. I think the dose is 0.5 milligram to 4 milligrams of methylene blue will inhibit nitric oxide. So per kilogram.
Yeah, it's inhibiting that guanylate synthase, and that reduces the production of nitric oxide, or at least inducible nitric oxide.
Now, let me add something here very important. Okay, it's all about the dose of methylene blue. In lower dose, because it buffers the redox, it scavenges the free radicals, it increases the nitric oxide.
Right.
And in inhibition, it happened in the highest dose, which we needed when we have vasopressoric shock or septic shock. So we're talking about the dose that we're using does not interfere with nitric oxide. In fact, it increases nitric oxide bioavailability because it helps to scavenge the free radicals, so the free radicals will not react to nitric oxide. So that's mean it will increase the nitric oxide. But when it's high dose, it does inhibit the nitric oxide synthase, especially the inducible nitric oxide synthase, because there's two types of them. The inducible, which is the macrophage has it, and then the endothelial one, which is the endothelial cells. It's mainly focused on inducible nitric oxide, which we need it when we have septic shock, when we have too much of nitric oxide. And peroxynitrate, that's not the nitric oxide is a problem, it's also the peroxynitrate, which is free radical that cause damaging. That's where we need to stop the nitric oxide, especially the inducible one, from overproducing this nitric oxide, which will turn into peroxynitrate. So that's very close. You can still use nitric oxide supplement with methylene blue. In fact, they have synergistic effect because at low dose, it's basically a redox buffer more than inhibiting the nitric oxide synthase.
Okay.
And I would also add to that, guys, that it depends on what you use as a supplement for nitric oxide. If you use something like that Berkeley Life nitric oxide, where you're making nitric oxide directly from sodium nitrite and vitamin C or whatever, forgot his name, but anyway, the nitric oxide guy. If you use that product, it would still create nitric oxide because it's not relying on the synthesis of it. But if you try to use things like arginine or citrulline or something like that, it wouldn't work as well because that pathway is the one that's blocked. So for Bill, what dose and how long would you see testosterone increase levels? That's a good question. So if you put your patient on methylene blue, and you're on maybe 10 or 20 milligrams a day.
1 to 2 milligrams per kilogram, and you'll start seeing an increase in about 6 weeks.
Okay, and what kind of increase do you think we would see? A heavy one or a small?
No, probably maybe about 10 to 15%. Not terrible, not a big increase.
Okay.
But again, one of the other ones I'm working on is 20 ways to increase or decrease hormones with non-hormonal substances. So that's in there. So
that's really interesting.
So,
but it's not affecting really estrogen levels so much, or the other hormones, it's mainly testosterone. Okay. No. And do you think that's because it influences the receptor sensitivity?
Yeah, that's exactly it. Okay. For psoriasis,
I'm curious.
Yep.
Oh, sorry. I just wanted to chime in. So it seems like the commonality really is that it has everything to do with the level of oxidative stress, and that methylene blue at low doses, but like you said, taking, or Dr. Beamer, you talked about taking the arginine or the precursors to activating nitrogen oxidase synthase. It seems like it has more to do with the level of oxidative stress, as opposed to it inhibits this and inhibits that, meaning that it's almost like anything that is really high in oxidative stress, then it gets buffered. And so there's an abnormality when there's that high level of oxidative stress. When there's not the high level of oxidative stress, then it's not going to inhibit anything. Is that a good way to see it, do you think?
Bill, what do you think?
Say it again.
Well, one of the things Dr. Joseph pointed this out
what
before.
I'm saying is sometimes we're looking through the lens of 100 different things that methylene blue affects. It inhibits this, it increases that, inhibits this, but really it seems like it's only buffering things or affecting things that are having too much oxidative stress.
Right.
That's anything exactly under a certain ceiling of oxidative stress, it's not affecting. Is that sort of that kind of resonates?
That it is, yeah. So,
and you know, Dr. Joseph, that ties in with some of the comments that you've made about, or observations that you've shared with us about your patients, which is, you know, with some of these redox related therapies, the patients that are kind of worse off or in a more dire situation, or quote unquote have worse oxidative stress, tend to be the better responders or have a more significant response. And then, you know, somebody with a lesser degree of dysfunction, you know, there's less impact.
Yeah, absolutely. Like, so if somebody is just looking to feel like they've got more energy or that more focus, if they're already fairly healthy and they take the methylene blue, they're not necessarily going to feel this like surge of energy. But it's not like it's not doing anything. It's going to buffer against anything happening. That's the way I see it. But yeah, those that are very sick. In fact, they treated somebody with IV methylene blue that was having a cytokine storm about 3 years ago, and he went from, you know, barely being able to stand up to, and he was lethargic, to standing up and having a normal conversation. So yeah, it seems like it's the level of oxidative stress, you know, when we do take the methylene blue, either IV or orally, that's when you really feel it. That's when it makes that big dramatic difference. All the other things are going to be sort of subclinical and almost always positive effects, even if you don't feel it.
Well, again, so the point is that, you know, in high doses, high nitric oxide, especially in like surgical situations, is not a good thing. You know, we're you know, the nitric oxide people are always telling us, take more, take more, take more. Well, you know, there's a ceiling here. And, you know, sometimes we can get in trouble, you know, having too much on board. So now you have, at least we have in our pocket something that we know that can reverse it, you know, if necessary.
Great idea. Yeah, great point.
Okay. Mike, maybe you can help me with this. For psoriasis, do you use top? I've never had.
Yeah, we've had some people do this. Let me tell you about methylene blue topically, like from a dermatology point of view. I've used it quite a bit on different things. And what I will tell you, in my opinion, is that without phototherapy, just methylene blue, like, you know, in a cream, it's about as strong as a lower strength or medium strength steroid. So like I'd compare it to fluocinolone, maybe beta-methicillin valerate, or triamcinolone. You know, it's in that category. It's not stronger than triamcinolone in terms of the effect that you'll see, but it's not like clobetasol, where it like will give psoriasis a complete kind of beatdown. But clobetasol is a big concern because it is the go-to drug, or even halobetasol, for psoriasis, and that really does damage your skin. And dermatologists never talk about the systemic effects of absorbed super potent steroids, but they must have some systemic effect. You know, so I think if we can use methylene blue, I think in combination potentially with a mild steroid for a balanced effect, I think that would be really good. Dr. Hepburn has used both methylene blue and ivermectin in her practice of dermatology and kind of evaluated it for psoriasis with good results. And phototherapy, as your lecture, Dr. Bill mentioned, that is great for psoriasis that is very bad, and a person's not a candidate to use any biologics or doesn't want to use them. Using topical methylene blue and photodynamic therapy is like a big gun treatment for severe plaque psoriasis.
Mm-hmm. Okay. And maybe apropos of nothing, but BPC 157 also sort of counteracts the long-term effects of the potent corticosteroids. So
really, oh, that's great to know.
Yeah, it'll actually reverse.
It's got to be oral, or can it be Can it be topical?
Topical or even injectable. You know, we'll do what IM. So makes
that's
it
a big thing.
Is hypertension a contraindication? I don't think so. Mike, what do you say?
I've never seen it be a problem. We got hundreds of patients on it, and I've never had one person complain they're having.
Yeah, I've not either. Is it safe to use with saline or just dextrose? We usually put it in D5.
That's a really good question. I get a lot. Do you have an opinion on that, Bill?
Not really. I mean, we just use D5W. So
yep, I do recommend D5. We've had people do saline, but one thing I will say about injectable methylene blue is it can clump. And one of the things is it's really important that it's not refrigerated and you don't take it out of the fridge, you know, and just use it. It tends to clump or even fall out of solution when you put the injectable product in the fridge. So be cautious about that with clumping. And I know, you know, you can see it sometimes in the line that, you know, and that does cause people concern. So we do recommend using a filter with it, just to be safe. I don't think that there's any problem really that would happen if like a little, if a kind of a little, you know, if there was some kind of congealing and there was a higher little temperature, because you're giving it very slowly, hopefully. But, you know, but I think my impression, and I can't speak to this for the technical or scientific means, but I think saline's more prone to clumping than dextrose. D5. So if you can use D5, that's a better choice. That's about it.
Yeah, I don't bother with it. We know.
Yeah, why not? That's what the instructions say too. Why go against the instructions?
I mean, you know, that's not something we need to you know stick our neck out on. Our neck's out far enough as it is. So.
Yeah. No, I'm with you. I don't recommend it. Yeah, but it has people do it.
Does Amex carry IV methylene blue?
We do. It's a lot cheaper than it used to be, guys. It used to be like $1,500 for the Probe Blue or whatever, and now it's $275, which is a great decrease in price. But it's still pretty expensive. That's for 100 milligrams of IV drug. So, you know, it kind of get expensive. We do have, I think, with the new popularity and publicity that methylene blue is getting, more of the IV pharmacies that do sterile pharmacy are getting interested. So I do have somebody that we're talking to that's kind of kicking tires about how much they might be able to sell to help get that price down a little further.
How about the price on? That was 100 milligrams, you said?
Yeah, it's 10 milligrams per mil, and it's a 10 cc vial, so it's a total of 100 milligrams, and then that's $275. You can shop around and maybe try to find it at Henry Schein. That's the best price we can get, is about that.
What about the oral?
The oral, we are very reasonable on it because we sell a lot of it. We're about, I think the highest price is $1.20 a capsule, and when you buy by the 100, they're about $1 a piece, basically $1 a piece or a little bit. But they're well under $2.
Any dose or?
Yeah. Though now I will say this, guys, we've been getting higher doses because I've been working with the Lyme disease society, the ILADS group, and they are accustomed to using some higher doses than we've used in our group, and we aren't having any problems. But they're giving people 25 and 50 milligrams twice a day. So we've gone up to carrying capsules up to 100 milligrams, or I think maybe 120 milligrams even, and those are a tad bit more. But they're all, the most expensive ones are like $1.50, so they're not crazy.
If it has the antidepressant effect, should it be tapered off when about to stop? The same as like any other MAO inhibitor. I don't think there's a whole lot of withdrawal from them.
Yeah, by itself, if you just have a patient on methylene
Yeah.
blue and they're not on an antidepressant, then
Yeah.
I don't think you need to do much tapering.
Yeah, I don't.
But if
Yeah.
they're on one, then you got a different matter, and you got to have a case by case talk about that one.
Yeah, can I add something?
Mhm.
Yeah, so I've had several patients ask me about that because they look online and they see that, and of course they get concerned, which I can understand. When I do the literature searches, or the last literature search I did on this, I had about 4 or 5 studies come up, and they were basically the only studies that I found, and they all seem to be with sort of more drug overdose scenarios. We're talking situations where a patient came in, they had taken an entire bottle of Zoloft, an entire bottle of Effexor, an entire bottle of clonazepam, and they were using the methylene blue to help buffer the redox, to detoxify the toxic effects, to keep the patient alive. And of course, they have to get very, very high doses of methylene blue. We're talking up to around 2,400 milligrams in a span of 24 hours. And the patient was a case study. The patient started to exhibit signs of serotonin syndrome, for which I don't remember exactly how they addressed it. I'm sure they turned the methylene blue off at that point, but it wasn't significant, and the patient ended up surviving. And I don't want to, again, stick my neck out too far, but that was the common thread. There were other cases where they gave methylene blue during a surgery. And again, the dose was pretty significant compared to, what we typically take. And so
I agree
the point
100%.
is that the point is these are more extreme cases, and the cases that were presented were not cases where patients, where they died. These are cases that patients exhibited signs of serotonin syndrome, but they ended up being fine afterwards. So to say for our low doses that we're using, no, you have to get off of your antidepressant, I think is I don't think that we have anything to be afraid of with moderate doses of antidepressants. And
I agree with you,
blue.
doctor. Yeah, I do agree with you. This is a common question. It's a really important one if you guys want to talk about it for a minute. I have talked to some psychiatrists about serotonin syndrome and MAO inhibitors and antidepressants. And one of the things they have said to me is that it's slow onset. It's not usually something that happens quickly, and it's very dose dependent. And we are using pretty low doses of methylene blue, but we are talking about raising them, and I'm seeing dosages kind of probably nowadays are probably the average dose is double what it was when we started this. So, and that's, I think, good because we've all gotten more confident as we learned. But I agree with you. I think some patients can remain on an SSRI or something without having symptoms. I think you just have to monitor them and also make sure they're not like failing to tell you, you know what I mean? Like they're like, I'm not even gonna tell you I see a psychiatrist, let alone what medications I'm being given. You're my integrative medicine doctor, So make sure they share it with you, because the people that we have had on methylene blue and antidepressants, the doctors were not told, by the patient that they were on antidepressant. But the psychiatrists basically say it's they don't expect to see it. And think of it this way: if the person's on 10 milligrams of citalopram, you could probably double that to 20 and there's not going to be any problem. So there's not this huge problem with methylene blue because it's not going to be as significant as doubling the dose of the antidepressant. So, but if they're on, 300 milligrams a day of Zoloft and they're on Wellbutrin to go with it, then that's a high risk patient there. So it really depends on what antidepressant they're on, what the dosage is, what the half-life of the antidepressant is, and how much they need it, and whether or not they could stand a dosage increase anyway. So you just got to sort all that out, and I'd be happy to. I always tell everybody just do it on a case-by-case basis and ask and get consult.
Yeah, and the other question is that truly a side effect, or is it that the methylene blue is, by optimizing mitochondrial function, buffering the redox intracellularly in the neurons, is improving their function and improving the amount of neurotransmitter production naturally, then it's the medication itself that is overdoing it, that the antidepressant then is, it's working too good. That's
I think
kind
both
of,
things are happening, Dr. Joseph. Like when you inhibit monoamine oxidase A, you're inhibiting the metabolism of all catecholamines. You know what I mean? So it's not just the serotonin, it's norepinephrine and some of these other things too can go along with it. But I agree with you. I think it's a fairly mild effect, and at low doses of antidepressants, because you don't see a problem with other catecholamines.
And so it's inhibiting MOA simply because in that scenario, then it must be because MOA is having a much higher redox reaction.
No, it's just direct. It's just a direct antagonist.
It's just a direct antagonist. So it's
it
not
competes
normalizing
for metabolism. Yeah, methylene blue competes for metabolism with catecholamines at MAOA, as Dr. Clearfield pointed out.
Okay. All right. Thank you. That clears some things up.
Let's see. What's the next?
I know Heinz body anemia.
That was my question. I don't know what that is. I know it's really serious. Is it permanent?
It's a hemolytic anemia, is what it is. So, it can come from propylene glycol. That's the usual.
Okay. Is it reversible, or is
well, again, methylene blue is an antidote.
Okay.
Okay. So, and again, it depends on the severity of it. G6PD deficiency. Quite frankly, I don't know if I've ever seen one, but if a patient had one, I probably wouldn't just stay away from methylene blue. I don't know, Mike, how you feel about it.
I agree 100%. Yes, it's contraindication.
What level of GFR should methylene blue not be used? Probably under 30. Yeah, under 30. Any evidence? Yeah, I think we did mention non-alcoholic fatty liver disease. Use it with N-acetylcysteine and photodynamic therapy. Again, 1 to 2 milligrams IV for 2 days, and then 5 to 10 milligrams twice a day. You can use that for several weeks, actually. So.
Have any of you actually ever tried it? Because I've tried. I've never noticed any difference on methylene blue at any of those, for performance wise or anything, for myself at least.
Oh, are you talking about taking methylene blue yourself? Yeah,
I've taken 10, 20, 30 milligrams. I've tested it out on the tennis court to see if it changes my ability to play or perform. I haven't noticed any difference.
Okay, that's a great anecdote. For coming from you, that's really good, because I can notice some differences myself, but I've been on it for a long time, but yeah, it's interesting. What would happen if you took, a 100 milligram dose? Would you see a change in your athletic performance? That's great to know. I don't know.
Well, that goes back to what I said earlier. I mean, if you're you're a peak performer, you're healthy, you're younger, your body is already buffering the redox and balancing oxidative reduction reactions appropriately. So any advantages would be almost subclinical, just as a generalization, and that it's the patients with uncontrolled diseases, high levels of oxidative stress, that are the ones that actually feel a difference more dramatically. Does that resonate?
Yeah, definitely.
But what you are measuring it.
Stop lifting weights all the time, Steve.
You're too healthy, Stefan. That's the problem here.
Yeah. The other thing is that it's not just healthy. He said, I did not notice any difference in my performance. The question is that, are you comparing it to creatinine? Those ones are storing the ATPs. It's going to be different. I mean, the mitochondria activates the mitochondria, but it does not really cause increase in the storage of the ATP versus creatinine, where we use it for increasing the endurance of and performance. So here's the thing: and it's good for intellectual and cognitive function, but how you can measure it and how you can detect it is just it's difficult to be done on a subjective way. It has to be some
Yeah, I
objective
prescribed it a
standards.
couple times, and I've had maybe 2 or 3 female patients. They'll tell me like they felt fantastic. They felt like described it as superwoman, and it seemed to last a couple sessions, and then I guess it saturated whatever it was to saturate, and they felt no further benefit after that.
Yeah, I think you're exactly right.
Well, it does help to increase the serotonin, so they give them that happy molecule, and it does give them that kick. But they want more of that kick. So when they get into plateau, then they say, "Oh, there's no more difference." It's relative. It's I don't think you can assess Methylene Blue by your own self. You need to really have some objective way of measuring the efficacy of it, not subject.
Now
Yeah,
I bought a hyperbaric chamber. It's coming in the mail this week. I'm wondering if we'll combine methylene blue with the hyperbaric, and maybe we can see some potentiation or synergy there.
Yeah, I'll come over and try that.
yeah, I really do see methylene blue just again, just as a generalization as for myself as an insurance plan. You know what I mean? It's an insurance plan. It's like it's like having an umbrella to cover for any, steep increases of oxidative stress, or we don't know when we're going to get hit with the next variant or whatever is coming at us. So having the methylene blue on board is that that buffer against extremes, and then having the light available. We had a gentleman at a church. He literally had the worst chronic sinusitis I've seen in a while. I actually treated him with 2 rounds of antibiotics, both for 2 weeks, and he still had pain in his cheeks. He still had very, very thick nasal secretions, and just miserable. And then we gave him methylene blue in the nasal spray with the intranasal light. And within a few days, he felt that he was cleared up practically all the way. So we just let him keep it and just keep.
And when he did his nasal wash, he said the first time he could not remember that he didn't have anything come out in the nasal wash. No green, no yellow, no scabs. He was very, very pleased.
Yeah, that was rapid, and these people, they don't exaggerate. This is very real. That was very dramatic. Something I had never seen before until using methylene blue. So the greatness and the beauty of it is in certain situations. But I understand, Stefan. You're trying to optimize your athletic performance, and it makes sense. I mean, if your oxidative stress levels are going higher as you're working your body more, or maybe it's helping with the mitochondrial function. But I think in your situation still, because that umbrella, you're still in the sweet zone. Those oxidative stress levels are not so abnormal enough to buffer, or maybe the effects are subclinical. It's just hard to measure. But yeah, there are situations where people can absolutely feel it. But I understand in your situation now, and even in my situation, I thought, when I would run, is it helping? Is it not helping? It was very difficult to tell.
Yeah.
Yeah, let me add something very, very important here. And to appreciate methylene blue, it's the only drug that will help to detox spike proteins, and the only drug that helps to prevent spike protein to polymerize into prions, which leads to Alzheimer. And evidence of that, Grifols Company, which is a company who are selling convalescent plasma, in order to make sure those plasma are completely free from any germs, whether it's viral, bacteria, or fungus, they put methylene blue in it, and then they pass red light on it just to disinfect the blood completely from any germs. And the methylene blue does have tendency to attract to spike proteins. It also has tendency to attract to any viral RNA or bacterial DNA and RNAs. They just have more tendency, even with viral, than your own cells, DNAs. And so it's a detox for the RNA spike vaccine, which vaccine injury, and also it's a detox for the protein itself. That itself, I would definitely recommend it for all the patients who are being in COVID, post-COVID syndrome, or COVID acute, or I think it's the best treatment for patient with the vaccine injury from the spike protein or the spikeopathy, according to Dr. Celebi, the spikeopathy.
Psychopathy. Yeah.
Well, very good. Well, hey, our next question is that Dr. Clearfield, did you mention anything in your lecture about recurrent UTI?
No, I didn't really come across anything like that.
Yeah, I would discourage that.
Yeah.
You know, the reason you didn't find anything either.
I didn't know.
Yeah, I've been asked about that. I think what it was, guys.
Wait, you said the UTI?
Well, hold on a second. There used to be an FDA-approved drug that had 50 milligrams of methylene blue in it, and methanamine and some other things. It was an old-time drug, and it was removed from the market for lack of effectiveness for UTI because, you know, that we got Cipro and some of the other things that were working better. So I wanted to bring that up, but I have not, people I think remember that, but I don't know how effective it really is for UTI, and I'd be really kind of cautious.
I think it's very effective. I think with Dr. Joseph James has a case where all the antibiotics failed to manage her. Dr. Joseph, do you remember the case when you give her methylene blue? Are you there?
Oh yeah. This was a case with this was a young female, 20 years old, who had recurring surgeries, like multiple surgeries, like 25 of them for ureter stricture, ureteral
reflux, yeah.
Reflux, yeah. And so she had significant stenosis regardless of how many dilatations they did. And so she had sort of a persistent hydronephrosis all the time in both kidneys. And the particular situation was she had, I believe it was the Delta virus infection, which was more severe. And she was really having difficulty. And so she was in Texas, Houston, and her mother was very concerned. And so I overnighted methylene blue to her, and she got it just in time and took it. She was just about to go to the hospital because she was feeling like she was having some difficulty breathing. Also, at the same time, she knows when she's having the kidney infections because of the level of pain was increasing. And then she kind of kept sort of a chronic sort of pain in her kidneys as well. So there's probably some like a low, maybe a low grade infection all the time, or maybe pressure. And well, not only did she improve pretty quickly from the COVID infection, but after she finished the methylene blue, I think I gave her about 10 or 14 days worth. She told her mother, she's like, wow, you know, my kidneys actually feel great. What is that stuff? And so, you know, without having any objective lab testing, it became obvious that the methylene blue would be very effective for her to take on a regular basis, not only to, you know, oh, and I gave her a red light as well that she could shine, the one that has very deep penetration, 2 prongs, very deep penetration that we were using for more deeper tissue cases, that she could aim at her kidneys as well. But yeah, that's a great situation where the methylene blue was a true hero.
That's awesome.
Yeah.
Okay. Well,
Yeah.
good.
Yeah. So, you know, I don't, you know, I'm not say that, and I'm not trying to exaggerate to make methylene blue, you know, look better than it actually is. But those are real cases where that was the prime determinant, just like with a cytokine storm, or, you know, extreme situations, chronic hydronephrosis. And why not try methylene blue if you're having a low grade UTI. And you can even aim, if you have a red light, a more penetrating red light, you can aim it at the bladder. Perhaps maybe that works. Why not try?
Yeah, you bring up a good point, and that brings us to our next question. And by the way, Dr. Clearfield,
can you go ahead and see the study here that I'm putting it on?
Yeah, there's one here, and this is the drug I was talking about with methamphetamine, and notice they call it a urinary antiseptic. They're not calling it a urinary, antibiotic. It was
Right,
20.
because it has a broad spectrum of killing all the germs and the biofilm without much of resistance. It's not just for bacteria, but I think it's a good. This is a good study.
I think it's a good adjunct. Do you guys know what methamphetamine is? Methamphetamine breaks down into formaldehyde in your urine. So it's actually creating formaldehyde in your urine. And that's the active ingredient in that drug, really. I think the methylene blue.
I can add in the one that I've used quite a bit for a long time, 30 years, is Beriberi vulgaris, is a homeopathic remedy, and that's quite effective for pretty much any type of urinary issue. The liquid is better than the pill form. We're having trouble finding the liquid these days. We've had successes where we had a 1-year-old baby was going to have a nephrectomy, and we gave it the Beriberi, and saved the baby's kidney on it. It had chronic urinary infections pretty much its whole life. So we gave it some of that, and 6 weeks later, urine was cleared, and the surgery was canceled, and that was 15 years ago. And still, it's not a baby anymore, and it still has both its kidneys. So
there you go.
We've used that a lot for patients, especially females who have chronic urinary infections. It seems to work quite nicely. It's very non-toxic at all. The pellet form's not quite as good as the liquids, and I don't seem to be able to find the liquids these days, but it works quite nicely. So that would be probably my go-to before methylene blue, but that's just me. So
okay, well, Bill, we got another question for you. I think you covered this in your slides, but you might need to revisit it. The dose for malaria and dengue.
I know it is. I don't have it off the top of my head.
It was a real high dose, I remember seeing.
Yeah, it was like 60 to 120 milligrams a day, I think it was. I'd have to go back to the slides.
Yeah, we could look that up, but it's going to be and the other thing just on dosage is 2 milligrams per kilogram is about as high as you want to go before you start to see side effects. And some of these studies are recommending dosages higher than 2 milligrams per kilogram. So just be cautious that above 2 milligrams per kilogram, which is a stout dose, I mean, that could be a 150 milligram dose.
Yeah. I'll make I don't have it right now off the top of my head. Once we start talking about things, my mature brain starts to get a little bit sort of confused here. So.
Well, the study will be in your references because you referenced all your studies, so it'll be.
Yeah.
What's the next? The next question we have is, let's see. Oh, dermatology of methylene blue with ivermectin. Is the ivermectin topical? Yes. Mm-hmm. The answer is yes. 1%. So yeah, that's ivermectin and methylene blue can be used together in a topical, and it's 1% is the ivermectin dose. The methylene blue dose is 0.05 to 0.1%, something in there. Okay, question for you, Dr. Clearfield. Does methylene blue increase vitamin C uptake or decrease, and can you use together in an IV?
I wouldn't use it together. Again, that's another one that I'm usually not sure about these things. Vitamin C seems to affect a lot of other substances, so I usually try to do that separately. I don't know, you probably know better than I do, Mike.
I agree,
but it's used for as an antiviral and antibacterial, and then use it with a lot of other substances. But it seems to lyse some some nutrients and you know, sort of inactivates them. The main one being glutathione. So you really need to keep those separated. Does methylene blue increase IV? You know what? I don't know the answer to that one. You know that one, Mike?
Does methylene blue, is there a benefit to pass methylene blue IV through UV lights before it goes in the patient? No.
Okay. No, the question before, IV, does methylene blue increase IV vitamin C uptake?
No.
Okay. All right. So methylene blue and biofilm, yes. Candida, yes.
Yep.
Is there a worry about any supplements or medication interaction? Yeah, the SSRIs, you know, the antidepressants. Those are the ones.
To include St. John's wort, right? St. John's
right.
wort.
And SAMe also.
SAMe, yeah.
Yeah. I recently prescribed my liposomal methylene blue in capsules. The bottle indicates need to refrigerate. You mentioned not refrigerating. Again, you need to refrigerate the liposomal ones, Mike.
Yeah, let me clarify what it meant. When we were talking about not refrigerating it, what I was talking about is if you, like, for example, if you take and you have a vial of sterile methylene blue, and let's say you make up a couple of bags the day before for your patients coming in the next day, right? Let's say you have 2 patients coming in, or you make them up that morning, and then you throw them in the refrigerator to get cold and keep them cool, you know, and hopefully sterile and all that kind of stuff. The question is, don't do that. They need to be really at room temperature before you administer it. And same thing with the vial. Like, don't put the unused portion of the vial in the fridge, which is the good place to store it. But if you're going to use it, you need to really let it come to room temperature, shake it good, and make sure that, you know, it hasn't got any like congealing of the methylene blue in it or anything like that. So that's just with the sterile. Now with the liposomal stuff, really what that is liposomal cream, and they're just putting it in capsules. Okay, so yeah, you can refrigerate liposomal capsules. I'm not sure how much that's needed. We know that methylene blue penetrates really, really well, but maybe for cancer therapies that's needed, or something like that. But yeah, I would follow the manufacturer or the pharmacy's instructions. If you bought something they say to refrigerate it, I would do so. That just my comments were regard just the IV and you know, IV admixture.
Even if the vial has been punctured, methylene blue still not needing refrigeration?
That's a good question. Now, the vials are single-use vials. They are not preserved. Okay, so there is no preservative in it other than the methylene blue. So yeah, if you're going to puncture a vial, I think it's best to use the whole vial and make bags. If you know what I mean, like, especially if you know that you're going to use them very quickly, like within 1 or 2 days, you know, you might just make up your bags and put them in the fridge and then just be done with the vial. Technically a non-preserved sterile product, once you puncture the vial, you know, you're supposed to use it maybe within 24, 48 hours or toss it. But I would definitely recommend refrigerating that. The key is we were refrigerating for sterility reasons, and that's a good thing for sterility. But it also, the reduction in temperature causes the methylene blue to be less soluble in the water somehow, and it just tends to clump more. I'm not trying to overstate this because I don't think it happens often, and I don't think it happens every time, but it's just something that can happen. So I'm just calling your attention. I have had phone calls of people who literally had a patient with the IV in their arm, and they're like, there's a clump in the line, what do I do? So I have had 2 calls of that nature. And it's from having the bag be refrigerated before it was hung. That was my only point.
Yeah, methylene blue is very interactive, so I don't like to mix it with anything unless you have a filter. If you have a microfilter and all that, you're safe because nothing will pass above 100 nanometer. But they are the methylene blue, it's an antibiotic. It's preservative itself. Shine red light on it if you want to warm it up. Just keep
That's
all
a
the
good
shine
point.
red light next to you. It just helps to kill any germs, anything like that. But again, you know, try to use them. It's better to use the whole thing. So just to keep a peace of mind. I think you need to have patients scheduled to that day where it will be worth it to open a vial, or maybe Mike Beamer will come up with smaller IV dose if necessary.
Mm-hmm.
You know, I mean, I tend to something like this. I get it and use it right away, so it's not sitting around. So
Yep, absolutely, for sure, the best.
I learned that one the hard way with exosomes. I had a storage tank that I had 10 exosomes in it, and it defrosted. So you know how much those are.
Oh
Yeah,
no,
about $40,000 worth of exosomes that down the drain. So that happened once. That won't happen again.
That's
Yeah.
painful.
That was not a good day.
It's a bad day, yeah.
Yeah.
This is Dr. Patel, and I have a question regarding the dose. What we are saying, the dose to be used, but when I use that dose, 2 milligram or even 1 milligram per kilogram, it's very high dose for delivering by intravenous route.
I agree with you.
When I'm giving more than like 10 to 15 milligram, patient starts having some shakes and some reactions. So I have a big question that how many of our attendees are using the IV methylene blue and have no reaction at the doses which you are mentioning?
I never
Well-
used above 25 milligram at once.
Yeah.
IV. That's because I think it's enough to, even for my dad when he has that problem. I did recommend 25 milligram. I did not recommend IV 100 milligram at all. And I don't like to be recommending those high doses because we don't have much of cases to prove there's any difference. So, but if there's anybody used 100 IV, I mean oral, I'm okay with that, but IV, it's a different scenario.
So that's what I want to just make sure that everybody understands, that if they end up getting the IV methylene blue and start injecting and patient having reaction, they don't know what to do next. So, and patients many times have chills. Now I'm not giving more than 15 milligram. And I have not seen reactions, but the patients, those who experience the reactions, they don't want to go even near it. So
Is it the dose or how fast you're running it?
no, we are not running fast.
Okay.
It's the dose.
Okay.
I mean, I don't think that you can, I mean, 250 ml bag, you can run in an hour and a half. That's not fast.
Yeah,
Yeah.
Dr. Patel, my understanding is that your patients are pretty ill, and
Yeah, but that's the
and I-
reason
and I-
I'm using it. IV
Yeah.
these are all
And
cancer
I-
patients. Most
I
of them
told-
are cancer patients.
yeah, so I'm totally agree with you that we have to come at this conservatively, even though the literature says there's a certain amount of milligrams per kilogram. I'm just coming from a intuitive standpoint. Even the gentleman I treated with a cytokine storm, I believe it's 10 milligrams per milliliter, correct? For
Yes.
okay, and I believe I only gave him one cc in a bag of 500 cc bag of normal saline, and he improved dramatically. But I can't really, but he was in his home. I can imagine in the hospital setting, in the emergency room, that's the place to do the very, very high doses. Like I said, the one case of drug overdose of antidepressants and benzodiazepines, the patient was given, somewhere around 100 milligrams of methylene blue per hour.
So what do
You know
you
what I
think
mean? So
about
that-
using in the long hauler with really problems with the neuroinflammation? So if the orals are not working effectively, would you give them IV? Because I'm thinking of giving one patient who has come with a long hauler, nothing is working, tried oral, but it's not working well. So if I give her IV, what would I expect her? I mean, good effects, yes, but what would be the the side effect that I should be ready for?
Again, if you do 20 milligram and 25 milligram, you don't go above that. I don't see any side effects will happen, and you will see the patient has more clear mind, and the fog is run away. Do you know that if you take autopsy of that patient just at 1 hour from doing the methylene blue, her brain is literally blue in color, like blue. So that's the reason why I like ivermectin versus methylene blue versus ivermectin for post-COVID, because ivermectin does not penetrate the brain. We don't want it to penetrate the brain
But this is the long hauler.
yeah, long
She
hauler.
had it
They
in
have
November. She
yes,
had COVID in November.
right.
And
They
still
still
she
have
is sick.
inflammation, the neurogliosis. They have the neurogliosis is causing the long haul. There's inflammation of their brain, and that's causing the brain fog. And you're increasing the mitochondrial function, plus you are inhibiting the Th17 with methylene blue. You will not get that results if you're using ivermectin with those patients. So I will do IV methylene blue. I will expect the patient will have their brain fog will be cleared after that. In addition to other things you do, oxytocin, NAC, things that we talked about.
Yeah, I was going to say, my
Would you give
approach,
NAC as a IV, or would you give NAC as a oral?
Well, you can give it IV too, NAC too. If this case are severe and you want to get some, rapid results, you can give NAC IV. You can give methylene blue IV. You can also inject 2 international units of oxytocin around the umbilical, things like that, or intranasal. Those are 3 drugs and then Benadryl. I will definitely give them Benadryl 25 milligram, 50 milligram at night. And you can give Benadryl IV as well, and they will feel very good. My wife, she had the post-COVID-19 and rash and headache and all that stuff. And after 1 hour of IV Benadryl, 50 milligram, she's completely cleared. So Benadryl, methylene blue, and NAC,
I'd be
oxytocin.
asleep for a week.
Yeah,
Well,
yeah.
no,
That is the one thing that my patients don't
Well,
want.
Right.
Benadryl.
yeah, well, yeah, and I'm going to do a presentation in about 2 or 3 weeks on a mast cell inhibitor that I really like, and I had to find it. Okay, because you're right. It's hard to find. It's either going to be sedation or it's going to be not strong enough. And there's one called amlexinox. I can finally pronounce it. And I mean, this drug it's affecting the Th17, Th1. It's mast cell stabilizer, against histamine, leukotrienes. There's studies showing its effects on neuroinflammation. It's fantastic. It's
Where do
non-sedating.
you buy, and what dose are you giving?
I'm getting it from Pure Pharmacy in Carmel, Indiana.
10 milligrams.
10 milligrams 3 times a day is needed. And the other
Can you spell it? Spell it. What is your name?
it's 1 dose, or it's 40 milligrams.
Amloxanox.
Yeah,
I'll put it in the chat.
I'm sorry. Yeah, it comes in 40 milligrams, and it's 40 milligrams 3 times a day is needed. What was the question?
What was the name of the medicine?
It's amlexinox. So it's A, M as in Mary, L, E, X is in X-ray, A, N is in Nancy, O, X is in X-ray. And now the other thing I'm working on for post-COVID, for the brain fog part of post-COVID long haulers, because another thing, I've been focusing actually for physical performance on the methylation cycle, and that's a whole nother lecture. Like myself, my physical performance was great, but I still had issues with brain fog, some good days, some bad days. But the other approach I'm going at is this idea that, and they said it at the conference down in Texas, about the brain not being able to detox at night, or how important it is. And this idea of the lymphatic drainage having difficulty because of perhaps there's a difficulty in the pumping action due to sympathetic overactivity, and you know, the functioning of the hypothalamus is not working as well, you know, due to the neuroinflammation in general. But trying to figure out how to get that delta wave sleep, which is a requirement in order to get into the REM sleep, in order to get the full detox effect. I think that's the part that's, no matter what we do, is inhibiting our ability to get past the brain fog part. And you know, and that's where I'm actually considering. And people, you know how we think of sleep apnea is like, you know, you either have it or you don't. I'm beginning to think of it as an optimizing approach. That, look, if you're not getting better, I don't care if you're 30 or 40 or whatever, we got to check it. I don't care if you don't look like somebody who has sleep apnea, we're never going to know. And so optimizing sleep just for the purpose of helping the brain to detox, I think is a fantastic idea. And then there's delta wave inducing peptide in nasal, which you're aware of, Dr. Patel, I know.
DSIP? Are you talking about DSIP?
DSIP is, they now even make it in a nasal spray form,
Right.
at Pure Pharmacy. So we start combining some of these things and then thinking, and this is, again, this is intuitive medicine here. I'm still looking for the you know, direct evidence that, hey, they took a long hauler, put them on a CPAP machine, measured it, put them on a CPAP machine, and took the DSIP and they got better. But I'm thinking that that's the thing that's stopping us from actually getting these people better. And I know from my journey, it's just like, it seems like no matter what I try, all the things that should work don't necessarily work. And it makes me think, I'm wondering if it has something to do with the sleep, that we don't realize that we're not detoxing or releasing the cerebral spinal fluid, or the production of the CSF by the fourth ventricles are not able to get that fluid out of the brain.
But Joseph, you remember that a while ago you were saying that you used some prednisone or Cortef, I'm not too sure, some type of cortisone, and you had a great response. Was that cortisone or was that?
Yeah, low dose. Well, yeah. I mean, steroids fix everything, right? The problem is the underlying problem is still there. So I'm having to take the low dose hydrocortisone. Yes, it allows me to function. It's great. Or if a shot of Kenalog is like wonderful. But yeah, and we agree, we're on the same page. It's not fixing the underlying problem, which is the inability of the brain to detoxify properly at night. Due to
let me add something.
But what about the peptide TB4?
Peptide what?
Thyrosin. I mean, thymosin beta peptide. That works on a neuroinflammation. ARA works on that, and methylene works on that.
It's great. It's great. But what if there's there's enough neuroinflammation, that there's enough sympathetic overdrive, and there's just enough sleep apnea along with it, the enough brain swelling, neuroedema, and there's just enough sleep apnea.
Well, then try Dr. Halassa's Benadryl.
Well, yeah, let me go ahead with Benadryl.
That's symptomatic.
They have a very broad perspective about Benadryl, okay? And we have two cases, I think, presented with post-COVID-19. First of all, Benadryl is the best drug because it's non-selective antihistamine. So it covers all the histamine receptors. And when I try to bring it up in FLCC, they dodge it. Because why? Because they use, all those selective, the new ones, the famotidine and all those ones do not penetrate the brain, and it's not, it's for allergy, but it does not get into the brain for the reason, because they don't want to have the sedative effect of it. No, we want the sedative effect of it. The reason why, because post-COVID-19, they have mast cell activation syndrome, and their brain is full of histamine and glia inflammation. And the only way, and even not just that, the neurons and reticular formation for insomnia is actually histaminogenic neurons. So you do have overactive histamines, and that leads to the insomnia. Now, all the drugs that we use for sleeping, it does cause a problem next day, which is, you feel groggy and fatigue, and you don't get the quality of sleep. Benadryl gives you the quality of sleep that you're looking for without the side effects of addiction and rebound and dependency. And I would do recommend it strongly because I see a miracle in front of me, especially with my wife. She has this problem, and she went to the hospital. I was not thinking that they would give her IV Benadryl. They give it to her, and in 1 hour, she's completely resolved from headache, rash, fatigue, nausea, vomiting, all that stuff. So, is the spike protein activate the mast cell directly? Yes, we saw that, and when I presented that the spike protein activate the mast cells, and it's big part of the pathophysiology post-COVID. So giving Benadryl, you can start with 25 milligram if the patient cannot sleep. And if the patient does not sleep and she doesn't have the deep sleep that you're looking for, whatever you do is not going to work. And the reason, especially brain fog, because you
Dr.
need that
Halasa,
sleep to detox the brain. Yes, go ahead.
do you recommend of measuring the spike protein in long haulers or the antibodies or anything? Measurement, not just the yes or no.
You mean you measure the spike protein, or you measure the histamine?
Yeah. There are people those who are doing that.
Yeah,
Eh,
there is.
And then the patients, oh, I did that and it has not gone down, and I have continued to remain sick. So there is not much reported on that. So
they don't encourage it, the mainstream medicine, the big pharma, about detecting spike protein in the urine and the feces as a clinical. They're using it for environmental. Do you remember when they went to the sewage and they are detecting spike protein there to know whether it's epidemic or not? That similar test you can use for stool testing. But the big pharma does not want this test to be FDA approved. The reason why, because this will negate the whole idea about this is biodegradable RNA, and there are some patches are not biodegradable and they stay longer. So this will definitely defeat their purpose of selling vaccine, and it's not something good for them to be FDA approving the spike protein testing.
We
But
talked specifically about that, and Dr. Halasa was there. Ryan Cole is working on a test strip for this, but and it's coming from the pathology staining world. They're working on something like that. But
there is some lab in California.
Oh, the antibody test is out there, but they were talking about like a home test strip or something that you could use in your office. That would indicate, be like,
the antibody is not sensitive. You want the antigen. You want
that's
to
right,
detect
exactly.
the spike protein itself or the spike RNAs. That's what you want to detect, right?
They can stain it, and you can use a UV light or something to see the stain or something.
The big pharma does not want us to be passing those FDA approval for those tests, because it will definitely damage the whole reputation of the vaccine. Because they say, oh, this spike protein will finish in a couple of days, maybe months, and completely, or there will be no spike protein. And think about that. We have the spike protein continue in 1 year. So this idea of vaccine is biodegradable, it's not true. And they don't want any company to be proving it's and where irony is, they are using it in epidemiology to detect, let's say, if you have an epidemic in a certain area, they go to the sewage and they detect the spike protein there, and they say, oh, the epidemic is high in this area because we detect spike protein in the sewage.
But I have a question regarding, if let's say that the validity of doing the spike protein assay or not. So if you do the spike protein assay, and if you find that how many percentage of patients with the long hauler, they do have a persistent presence of spike protein, like any persistent diseases like Lyme disease, they have a persistent positive presence of antigen. So if we find that, then our approach would be, wouldn't that be different than what we are just saying that?
Who's going to do it? Who's going to pay for it? The big pharma are
I
not
understand that. I understand that. But
right.
but let's say that if it is present, we have to really think if it is present, then how would we treat those patients?
And that's
If
what
they
we
have
said. We
high
said
load of
Methylene Blue.
antibody.
Methylene Blue is the best way of detoxing. We know the Methylene Blue has affinity to attract to the spike protein, and not just that, even the spike RNAs. And that's evidence. Methylene Blue we use for viral infection, and it has a tendency to react with the RNAs. The RNAs of the viruses and bacteria are more negative redox potential than the human RNAs, so they prefer attracting to those pathogenic RNAs versus the human RNAs and DNAs. So yes, so what I'm saying is that Methylene Blue is the best way of detoxing those spike protein and RNAs. You add the Benadryl, which is for the mast cell activation syndrome. I think it's the best thing out there because we have publication for it. Then you add oxytocin, right? And then you add the NAC. I think all of this would definitely help, and maybe some other Th17 inhibitors that Dr. Joseph James,
Yeah.
the drug that he's mentioning about it, is going to present it, and also KVP, which I'm going to present it. You know, the melanocyte stimulating hormone peptides, the 3 amino acids. This is a very good one as well. I'm going to present it maybe 1 month from now. But I think you have the tools now. You have the Benadryl, Methylene Blue, NAC, oxytocin, and many peptides that we talked about. And I think we have the ability to manage post-COVID-19, especially the insomnia part. Very important, you know, if you don't manage insomnia, everything you do is not going to work. So very important to ask this question: are you sleeping at night very well? And if they don't sleep at night very well, especially with this post-COVID, give them Benadryl 25 milligram at night, and they will not wake up crogging, all that stuff. If they did not get the 25 milligrams, is not enough for them to sleep, you can go up to 50. I have a lot of people here in this room. They have some insomnia and all that stuff, and myself, okay, because I also have what we call the irritable bladder syndrome. I wake up at night a lot because I have neurogenic bladder. And because antihistamine does have anti-muscarinic, it's just a miracle, because now I don't wake up at night as much with Benadryl. So it's good for that. And then why I like Benadryl, for some reason you don't know, is that 50% we have chance of having cancer, right? Benadryl, according to big publications, it does help to decrease the risk of cancer, because it shifts the immune system to Th1, and we already our immune system is compromised, whether from COVID, from the fungal infections, from the environmental, from the food. It's very rich with all those triggers of mast cells. And because we are in this 2023, all of us, we have some degree of mast cell activation syndrome, that increases the risk of having cancer, putting risk of cancer. So if I use it, not necessarily religiously, let's say I use it for once a week or twice a week, just to adjust my sleep and balance the immune system to prevent having the cancer, because we're looking for anything that reduces the cancer from flip of the coin 50%. So this is something I will definitely recommend it 100%. Now, especially with the lifestyle that we're living, and the style, the city style, and the food that we're eating now. If you talk about people who are living in the mountains, where they're not exposed to those carcinogens, and they're not exposed to those mast cell activation syndrome drugs or chemicals, they may not need the Benadryl. But us, because we live this plastic environment, and one of the things about plastic, I went to Dr. Patel's house, and I have a dinner, and she has the food of the Indian is the best, because they have the spices and all that stuff. And although there's no meat, it's vegetarian, but it's so delicious. She does not use plastic at all. I didn't see any plastic in front of me. Even the water bottles from glass. And all of what she's doing, it's real, it's working, because those plastic that we have, it definitely triggered the mast activation and put us at risk of having cancer.
All right, let me make myself clear. Sorry to jump in like this. I want to make sure that we're clear in understanding what I tried to say earlier. I do take Benadryl. Okay, I do take Benadryl, and it has absolutely improved my sleep. And it makes sense, because post-COVID fatigue is mast cell activation syndrome, as far as I'm concerned, and the evidence is all over the literature. Or you could make that conclusion the way I see it. Okay, and but even if you get a good night's rest, the thing that we don't know, this is what I'm trying to introduce new. people don't actually know if they have sleep apnea, okay? Or they have mild sleep apnea, and with enough neuroinflammation, it seems that, and we're talking about chronic people who are not getting better from anything. We're not talking about somebody who took Benadryl and then they felt better. You know what I mean? We're talking about somebody who is still chronically having brain fog, and, you know, myself included, but I have all these tools to alleviate it. How come it's not gone? Okay. Is it because my brain is unable to detox at night because I have sleep apnea? You hear what I'm saying? Because I have sleep apnea. Now, FLCC mentioned it in a lecture. I'm going to listen, you know, hopefully we'll have the recording. I can listen to it again. I spoke to an ENT, very successful ENT. Everybody at that conference were amazing. That anybody you talked to was a superstar there. The ENT guy said, I can tell by talking to you, you have sleep apnea. He said, people don't realize it. And it's the thing that, you know, they get to a certain point and then they get whacked with some issue, a disease or something, and they just can't seem to recover. He said, it's because you have sleep apnea. There's a famous osteopath in England. Now they do more like chiropractic over there. And he's developed something called the Perrin method. And he's become super successful with it as far as getting chronic fatigue patients better, because he treated the old chronic fatigue before COVID came around with techniques, cranial sacral and you know, sinus lymphatic drainage. And one of my patients went to one of his trainings in Los Angeles, and she said his technique, this is what she said, that was being taught to the people being trained, that there's too much autonomic dysfunction, which is disrupting the ability of the fourth ventricle to the lymphatic system that drains the fourth ventricle, to drain it out of the head. Okay, so his technique is such that it affects the autonomic nervous system, allowing for the lymphatic drainage to happen, allowing for delta wave sleep to happen, because you need delta wave sleep in order to have that lymphatic drainage leave the brain. That lymphatic drainage contains the detoxing from the neurons that happens in the middle of the night. So my question is, what happens if you can do that and it takes a long time, you know, the natural way, like a couple of years is what she said. What happens if you have sleep apnea? Well, you don't get delta wave sleep. You might think that you're fine, but it's never been measured, and you're never getting better. You're still waking up with a headache. You're still having brain fog. Is it because you are not getting enough delta wave sleep, which is the phase where the detoxification and a drainage of the lymph fluid occurs? That's what I'm trying to say. So we can do everything, all these amazing things that we're doing, and we're missing the big point. You see what I'm saying? And these people with long hauler, there was an article that even showed they were able to show that COVID can get to the brain from the skull bone marrow, and from there gets into the brain through the meninges. And they were able to demonstrate this and show this and prove this. As far as I know, this was a study out of Germany. This is recently put out there. So what if somebody is virally shedding because they have trouble clearing the virus? They're getting a consistent amount of spike leaking into their brain from the skull bone marrow. They have persistent neuroinflammation, autonomic dysfunction. Their brain is trying to detox at night, but it can't quite, because they've got a low-grade sleep apnea. They don't get delta wave sleep, and the fourth ventricle is unable to drain itself, or that those toxins are unable to drain out of the fourth ventricle through the lymphatics out of the head. So they remain persistently inflamed. And yes, the modalities that we're doing are going to help. They're going to make the patient feel better, and it's going to help detoxify the spike. And the antihistamines are going to calm down the mast cells, but the cycle just keeps going because the underlying problem is still there. So that was the big point I was trying to make. I think this is the big aha, something that I'm certainly going to dig deeper in, and I'm actually going to get a sleep study myself, and I go first. But I think we might be surprised that this is the underlying problem that we weren't able to see before. I certainly wasn't.
Well, there's a big question. We are saying about Benadryl, but has anybody seen the report that you can get sleepy and better sleep at night with Benadryl? But what kind of sleep is that? Is it a delta wave sleep, or it is REM sleep, or what kind of sleep is that? Because it has to improve the sleep, but what phase you have more time?
Good question. I don't know the answer to that. Yeah.
But in reading, if somebody
I
finds
know
it,
we're treating the pathology of the insomnia, because insomnia of the mast cell activation syndrome is histamine, so you're blocking it. So we see that this is just more, and instead of using any other sedative sleep help aids, which does not interfere with the pathology, this is like you are stopping the histamines from causing the insomnia. I myself, when I take it, I go into deep sleep where I don't even remember. I mean, it's not the only thing that helps. We need to see if there's delta wave or not with Benadryl. That's why we're going to see it, and I will try to figure out or start to search it and see if there's any publication on it. The other thing about sleep apnea thing, yes, of course, sleep apnea is part of the inflammation of the brain. Ischemia, you would have it would trigger an inflammation of the brain, and using Methylene Blue is one way to help, but patients, they don't like to stick oxygen in their mouth. So is there any other options that besides giving continued oxygen at night? I will try with them with Methylene Blue at night, maybe help to, and definitely need to check the oximeter. But Methylene Blue is very effective to increase oxygenation of the brain. I saw it in a patient with COVID-19. Her oxygen is like 50. Her blood pressure is around 60/40. And when I give her the IV Methylene Blue, her oxygen saturation went up to around 80 to 90. It's like a miracle in front of you with that case. And her blood pressure went up to normal. So does the Methylene Blue helps to increase the oxygenations and helps to possibly, maybe that would be another answer for sleep apnea. They don't want to have oxygen. We want to try and see, especially for mild cases, but in severe sleep apnea cases, you really need to stick that oxygen or do some sort of jaw surgery where you pull this jaw forward. There's many methods of helping to, especially if it's peripheral apnea, to tighten up the throat. Central apnea, it's very difficult to treat. I don't know anything that helps more than maybe Methylene Blue, but if there's anybody knows about citrus.
And I'm 100% on board that, to try everything that we're doing. I guess I'm talking about those that nothing seems to get rid of it completely. It's going on and on for months and months. And I'm even thinking like, what if it was something where they showed up with mild sleep apnea and then they did one of the conservative masks, or even like an intranasal device, and it's pressure. It just maintains the pressure that that you're able to get that air in. I don't want to do that. Are you kidding me? Of course not. But if maybe it's something that you do for a certain amount of time until the brain inflammation goes away. If you see it from that angle, the neuroinflammation goes away, that the brain is detoxing, we're finally getting rid of the spike proteins, detoxifying, and that you finally get over it. Because my concern is that the longer we go with neuroinflammation, the more likely it's going to turn into autoimmunity and other things. Then it's a chronic problem. If there's a way that we can do even, a month or two of sleep sleep apnea treatment of the CPAP device, and maybe that clears it up, and maybe you don't have to do it forever and ever every day. But you know, I'm at the point now where I'm pretty sure most people, if nothing else is working, they'll be agreeable if they understand it to say, let's give this a try. Let's at least measure it and see where we stand. Because if you can't detoxify the brain, that this is more of an aha, you know, and it, again, based on the conference, based on other things, other evidences, you know, I could see how you just can't get. In fact, we have the gentleman, the guy with the chronic sinusitis, you know, nothing's going to work for him. He's got some other issues. He needs to, he actually has a CPAP machine. He's got to actually use it because his neuroinflammation at this point, everything I'm doing, nothing seems to work. The oxytocin nasal spray, and Methylene Blue, he's a situation where, you know what, maybe we have to do the CPAP. There's just no choice.
Right.
And hey, if it works, hey, if it's going to work, I certainly don't have a problem doing it.
Right. Regarding the question for Dr. Patel about
post-COVID, they have more.
Hey, Dr. Halasa.
Yeah.
Oh, let me let Colleen go. Colleen, you've been
Go
holding.
ahead, go.
Colleen's using some Methylene Blue and's got some other comments here, but why don't you share with us what you got going on, Colleen? You got to unmute yourself. Oh, there you go.
I know, I just did. I've been talking to Dr. Clearfield.
Okay.
Well, yeah, I'm just back when we were still on subject talking about urinary tract infections. I have a patient with prostatitis, really causing problems for him to urinate. So I've just given him Methylene Blue. I'll let everybody know what his reaction is. So let's see, I'm experimenting, and I newly put 3 patients, 2 with long COVID, brain fog, no, actually 3, on 80 milligrams BID of Methylene Blue, and a fourth one is vaccine injured. Of course, I have the nasal spray with the oxytocin. I was giving them ivermectin. I've kind of backed off on that after a week. And I did, for measurements of what was going on, lymphocyte map, Cyrex laboratories, and the Array 12, as well as the viral trio, which is a lab test by Immunosciences Laboratory in Beverly Hills for EBV, HVV6, herpes, and SARS-CoV-2. And all of them are showing extremely high levels of EBV. And they're fatigued and they have brain fog. So we'll see how it goes. They've only been on it 2 weeks now.
Great. Now let me answer Dr. Patel's question about the Benadryl and the Delta wave. Here's the article. It says slow wave sleep and inducing effects of first generation. That's very important that we use first generation histamine antagonists, which is Benadryl, one of them. And the present study was performed to see if the first generation histamine antagonists are useful sedative hypnotic drugs. It increases the electro EEG power spectra of the delta band, okay, in the frontal cortex, and the theta band at the hippocampus. And also this the H1 antagonist used in the study useful in decrease, that's a good thing, in the sleep latency. So that means it makes the people fall asleep very fast, and instead of waiting all night to try to trigger the sleep. And it increase in the sleep duration, which is very important, which is the slow wave sleep, which is the delta one. And the rabbit eye movement, that's one you don't want, the one with the dreaming sleep during the slow wave sleep was decreased by H1 antagonists for reduction in sleep latency from greatest to least. So what I'm saying is that I think H1 Benadryl is good for insomnia, does not have much of in other words, early morning, clogging and fatigue. There's some people are sensitive, and that's where you need to adjust the dose. Some people, 50 will be enough. Some people will 25, too much. Above 25, it's going to be too much for them. So that's where you need to gauge the dose. But again, the reason I like it just because I saw published articles, I think either in Harvard or in my clinic, where it says that it helps to increase the immune surveillance against cancer. And knowing all of this, and knowing that spike protein is mast cell activation, then I would strongly recommend at least twice a week, or just to adjust the sleep cycle. And if the patient can go with all natural ones like glycine, there's a good thing about glycine, helps in a natural way of sleep, but it's very important to control or manage the sleep. And if you have sleep apnea, of course, you need to manage it. If Methylene Blue does not work, then I think giving oxygen CPAP, it's critical and important.
Okay. Well, Dr. Clearfield, do you have anything you want to wrap up with, or any questions? Anything?
I don't know. I kind of got lost in the weeds a little bit here. So
I hear you. I know. Well, we kind of got off topic, which we stray a little bit sometimes. I understand.
Yeah, I know. It's okay. So this is let me see here. I'm not sure where this came from. Okay. Again, so this is I tried to give you kind of a succinct, this is how it works, this is what we use it for. Anybody wants the slides, I can either send it to Dr. Halasa or just get in touch with me. We'll get you those. All good thoughts, all good topics. So I hope you got like at least an overview, or sort of succinct way of thinking about using Methylene Blue. That's pretty much the bottom line. So,
yeah. Well, tell us about who you have tomorrow night. What do we have happening tomorrow?
We have Ken Crowley tomorrow night, who was on here. He's a regular for both of us, and we were doing he's just doing Cannabis 101.
Gotcha.
So kind of starting over from the beginning.
We're going to start with the Beatles' White Album and move forward to the Pink Floyd.
If anybody's interested, I don't know. Can I solicit?
Go ahead, doctor. It's your room.
If anybody's interested, I have a couple of students coming to Reno on the weekend of June 17th and 18th, and we're going to do some hands-on instructing. We're going to do a hormone pellet insertion. We're going to do Botox fillers, PDO threads, and we'll do some hormone cases too. So if anybody's interested, let me know. There's my email address. And if you want to come to Reno for a weekend or for a few days, weather's pretty good, and it's Reno rodeo weekend too. So there's stuff to do here. So if anybody's interested in that, those of you who don't know, we're on tomorrow night and every Tuesday night. We sort of do a parallel track with Dr. Halasa, and we have different topics, but we're sort of like linked arm in arm here, traipsing into the sunset. So we have Tuesday nights on Zoom, and again, if you're interested, here's my email address, and we'll get you the link for that. And it's like this, it's free, and anybody wants to present anything, please let me know. And that's pretty much it, I guess. I don't know anything else.
That's great. That's great.
Well,
thank you for coming. We really appreciate your time, Dr. Clearfield.
Next Monday, we're going to have, Dr. Elizabeth from FLCC, and she's going to talk about COVID in kids. But it's going to be a very great lecture. Hopefully,
Yes, I've seen it, guys. It's very good. I don't know were you there for that, Dr. Halasa? I don't know.
Yeah. She presented.
She's very good, and she's now very knowledgeable about vaccines. She's been on the forefront of the pediatric use of vaccines. She's one of the people who participates in the governance and her state of what vaccines are required by for children to go to school, this kind of thing. So she's really got an interesting perspective on COVID vaccines. and their role in children and all that kind of stuff. So and great depth of knowledge on other vaccines too. And interestingly, she's not all against vaccines. She really does like some certain vaccines and think they're extremely important, but others aren't up to par, and she'll give you the reasons why. But it's a pretty cool lecture. I hope you'll really enjoy it. So that's it for tonight.
Thank you.
Yeah.
Thank you, everybody. We'll see you again. And hopefully he'll be on tomorrow night.
That'll be great. Thanks.
Okay, thank you.
Okay, thank you, everybody. Good night.
Good night.